So my name's Sandra Collins and I'm part of the practice support team at Sydney North Health Network. So welcome to tonight's immunisation update. Thank you all for being here. We have an extraordinarily large audience tonight. And I'd just like to acknowledge Australia's Aboriginal people, the traditional custodians of the land on which we meet and work. We pay our respects and recognise their continued connection to land, water and community and honour their ancestors, elders past, present and emerging. As always, just a reminder about health pathways. I hope that most of you are familiar with it and had a chance to use it. The username is Health Pathways. The password is Gateway. If you have Top Bar on your clinical software, one of the apps on Top Bar will take you straight into Health Pathways with no login required. On the front page, you can see the latest pathway updates, latest news, alerts. As you can see there, there's an update on the immunisation for adults, which happens to be the Shingrix information that was added in August. To search pathways, you can use the index on the left-hand side. You're looking at my notes, aren't you? There we go. You can use the index on the left-hand side, or you can use the search function at the top. These are the pathways that are relevant to immunisation. So we've got quite a lot of information there. Please have a look and see what you can use. There's the Shingrix update. And we also have a COVID suite. And as you can see, it's quite extensive: clinical pathways, resource pathways, and referral pathways. These are monitored and reviewed and updated quite regularly to reflect the changing nature of the information that we're receiving. So please get on and have a look. So without further ado, I'd like to introduce Sally Edwards, who is doing the presentation for us tonight. I'm sure many of you are familiar with Sally. She's the clinical nurse consultant and immunisation coordinator at the Northern Sydney Primary Health Network. She has a wealth of knowledge and experience in immunisation. So over to you, Sally.
Well, let's just launch into it. We've got a lot to cover tonight. Going over the usual topics, the core education requirements, the schedules, current vaccine preventable disease activity. We'll cover catch up, adolescent and adult vaccination, and try to cover everything that's new for 2021. So with the core education requirements, you would be familiar, if you're an authorised nurse immuniser, with the 5 core education requirements that New South Wales Health put together for annual updating and to remain current. So I've put those first 3 core requirements into reading that I've sent out to my mailing list, and that is pretty static information that doesn't change much. I just update the links. So I sent that out about a couple of weeks ago. And then today we're covering in the face-to-face session the last 2 core components, and that's the immunisation schedule and basically everything else. If you're not an authorised nurse immuniser, this information and education is still very applicable to what you do as an immuniser. However, this does perform the function of having authorised nurse immunisers keep themselves updated. So the 2 topics that we're covering today, the immunisation schedule, those are current immunisation schedules, any schedule changes, the difference between the New South Wales and the national immunisation schedules, catch-up vaccination, school vaccinations, maternal influenza and pertussis, neonatal vaccination, and healthcare worker vaccination. And in the current situation updates, it's anything to do with current VPDs, any issues of concerns, and useful resources. So we'll go through all of that today. This is the NIP, the National Immunisation Program, which was last updated on the 1st of July 2020, which in my 7 odd years of working in the public health unit, I think is the longest we've gone without the NIP being updated. So this is a Commonwealth program. These are the vaccines funded by the Commonwealth and dictated to the states as to the minimum requirements that they need to provide their populations. And so that's what the NIP looks like for non-Indigenous people. There's also now a separate one for Indigenous people because they have a lot of additional vaccination requirements. And it depends on which state you live in as to what additional requirements are required. So that each of the states then take these schedules away and put together their own immunisation schedule. And this is what New South Wales looks like. You'd all be familiar with this schedule, I hope. If you don't have it, it's a very handy go-to guide, quick reference for what vaccinations we give. It's quite top heavy in the early years of life. That's when we do most of our vaccinations, pre 4 years of age. And then it goes in and covers those at-risk individuals, adolescents and adult vaccinations that are covered. And then there's the influenza also incorporated down the bottom. There's a little bit more detail that was included in this latest update, again, July 2020, so that they try to provide a bit more information about the vaccines, how they're given, the routes that they're given, and any particular information that's very important to know about, age restrictions and things like that. There are additional Commonwealth vaccines that aren't, well, they're funded by the Commonwealth, but they're not easily, they're kept in a separate place. They're not on the NIP. So those are the ongoing catch-up that the Commonwealth does for 10 to 19-year-olds. So anyone up to their 20th birthday are able to get these vaccines for free as catch-up. And for refugees and humanitarian entrants aged 20 years and over, they're able to get the DTPA polio, MMR, Hep B and varicella. The states, New South Wales then adds on to that, and they provide funding for hepatitis B vaccine for high-risk groups. So those people that are more likely to contract and transmit hepatitis B. They also fund HPV, which the Commonwealth doesn't, for refugees for 20 to 26 years of age. There's ongoing catch-up for anyone born on or after 1966 for the measles, mumps, rubella vaccination. And then there's the rabies post-exposure prophylaxis. So anyone that has been bitten by a bat, bitten or scratched by a bat in Australia, or a terrestrial animal anywhere else in the world in a rabies endemic area. So the only place in Australia we have rabies is ABL, Australian bat lyssavirus, which is a rabies type virus, very similar to rabies. So if you have anyone that's been bitten or scratched by a bat, very important that you let us know, and we provide that post-exposure prophylaxis. Whoops.
Talia, there's a couple of questions on vaccinations.
Sure.
On the schedule. One is a question on, are there any plans to make Men B, to add that into the schedule?
I'll go over that in a minute.
Okay, and the second one is about Gardasil and Boostrix. Practice saying they're seeing a lot of Year 7 children for Gardasil and Boostrix catch up. Is the school program suspended, and can they order extra Gardasil if GPs are picking up that cohort while schools are shut?
Good question. So yes, the school program is suspended with the school closures. There's no point in us going into the schools. It's also an additional risk, obviously, going into schools during the pandemic. So yes, our school program is currently suspended, and as far as we're aware, it's suspended up until the end of September. Same with the rest of the restrictions. So I wasn't, well, probably, if I'd have thought about it, would have been aware that there'd be increased demand of getting these vaccines at GP practices, but hadn't got that feedback. So that is a question I can ask of New South Wales Health. I guess they might prefer that we keep these in the school program, but because of the uncertainty around it, yeah, it would be good to get feedback on that. So leave it with me, and I will inquire whether or not you're able to get additional Gardasil and Boostrix vaccines. I mean, we're hoping that the program won't be suspended for too long, and we always do catch up in the program as well. Yeah, is that all to that question?
Yes, that was all for that one.
Okay, so moving on, who are entitled to free catch-up vaccines? This is a question that we get a lot because we often get lots of requests for individuals who may not be resident in Australia, maybe here on certain visas and wanting to know if they can get free vaccines. So, you know, the letter of the law is that eligibility for those vaccines are linked to Medicare benefits. So basically they need to be an Australian citizen, a New Zealand citizen, a permanent resident of Australia, applying for permanent residency, or covered by a ministerial order. So that excludes a lot of people that are over here on things like student visas. They may be here on different types of visa entries. There are humanitarian visas entries that they are able to access the vaccines to do with the Commonwealth funding, but yes, letter of the law, I say, it's linked to Medicare. If they've got Medicare, then they should be able to get the vaccines. That said, we're very keen to ensure that everyone is protected and nobody's at risk. So I generally say if they're under 10, don't ask questions, give them a free vaccine. And it's, you know, because what we're trying to do is minimise these diseases spreading in the community. These individuals are part of our community, so we need to ensure that they're protected as well. Okay, so the changes to the schedule, I'll just go over this again. It's not new. We went over this last year, but it's always good to reinforce what's different. And what's different to the schedule as of 2020 was the meningococcal ACWY, meningococcal B, the pneumococcal, and the Haemophilus influenza type B. And those vaccines specifically apply to at-risk groups. So the main standard immunisation program for children wasn't affected, but for at-risk groups, there were some changes, which I'll just quickly go over. So meningococcal funded now, always been recommended, but funded now for certain at-risk groups. Meningococcal B has been added to the schedule for Aboriginal children and certain at-risk groups. To the question about whether B will be added to the schedule, it's gone before ATAGI several times, I think at least 3 times, and it has been declined each of those times. The latest review was when they've added the Men B for Aboriginal children and some at-risk groups. And the reason for that is that the pharmaceutical company was unable to demonstrate a population benefit from the vaccine. You know, unfortunately, they have to take in costs versus benefit versus risks, and they did a determination, and so it was decided at that time that they didn't see a benefit to adding it for non-at-risk groups. So never say never, though. You know, B is now the primary meningococcal strain that we see. So if it's reviewed again, that may change. It's certainly something that a lot of groups are lobbying to have included. So it might become part of the mainstream.
Sally, just going back to the catch-ups,
Yep.
There's a question here. If they're over 10 but under 19, can they still get free catch-up?
if they're over 10 but under 19, well, most of those, yeah, I mean, again, with DTPAs, MMRs, anyone on or after 1966, yes, I would say that there's a benefit there. I don't know there's so much of a benefit of them getting free HPV vaccines, but you know, look, it's up to you if you know, you want to consider their circumstances. Technically no, but I'd say definitely under 10 yes, over 10 I'll leave it to your discretion. Okay, so meningococcal ACWY, it's only funded for these 4 conditions, so it's asplenia, hyposplenia, complement deficiency, and treatment with eculizumab. It is recommended for many other conditions, immunocompromising conditions that may place an individual at an increased risk of invasive meningococcal. However, it's only funded for those groups. Meningococcal B in Aboriginal children, so that's now on the schedule for 6 weeks, 4 months and 12 months of age. So very important that if you have Indigenous children in your practices, that you're offering the meningococcal B vaccine at those points. There's catch up for under 2 years of age until 30th of June 2023, so lots of opportunity to do recalls if you know you have Indigenous children at your practice. Prophylactic paracetamol is recommended before vaccination because we know that Bexsero does increase the risk of fevers following vaccination, and in particular if it's given in conjunction with the NIP vaccines. So the more vaccines given with meningococcal B, the more likely that they'll have a significant fever. And so this is the only vaccine that we recommend doing fever prophylaxis for, because it's very important to stay on top of those fevers. It has been linked with febrile seizures. So that's given before, usually 20-30 minutes before the vaccine, and given for 12 hours after, regardless of a fever. So parents should be counselled in ensuring that they're monitoring their fevers, but also giving paracetamol whether they've got a fever or not. The Men-B isn't required for the family benefits, so it is highly encouraged, but people aren't penalised if they're not opting for it. And there are additional doses required for people with asplenia or hyposplenia with immunocompromising conditions, and that's age dependent.
And then we've got a question on Aboriginal children and meningococcal B. What if the Aboriginal child comes back for the second dose or third dose after turning 2 years? Would that still be funded?
Yeah, I can't see why not. They've started it. Yes, let's finish it. I haven't heard official word on that, but I wouldn't have a problem with it. I can't see why not. We do that for other vaccines. The HPV comes to mind. So once it's started, I can't see why not. So meningococcal B, the at-risk groups are the same again: the asplenia, hyposplenia, complement deficiency, and treatment with eculizumab. And it is still recommended for other groups, so in particular HIV and hematopoietic stem cell transplants. Unfortunately, it's not funded. So there is an increased risk in those groups, but for whatever reason, they weren't included in the funding. Pneumococcal changes that came into effect, they streamlined those. You'd all be aware that they're a lot easier to follow these days. So that the changes came to all at-risk groups for all ages. And Aboriginal Torres Strait Islanders over 50 years of age without a risk condition are affected by it, as are non-Aboriginal people over 70 years of age without risk conditions. And Aboriginal children in some states, but not New South Wales. The National Immunisation Program pneumococcal vaccination schedule decision tree is a really handy tool to have, and that is a document. I've got the links on this presentation, which I presume will be circulated. I'm happy for it to be circulated after this, but this is a tool to assist people to determine dosages for the pneumococcal vaccine depending on the individual, so a very handy tool to have. And it also includes the at-risk groups. So you can see it's not greatly easy to see in small font. However, that is the list of all conditions that it is recommended additional pneumococcal vaccination in. However, the ticked conditions are the only ones where it's funded. So it's a very handy reference guide to have to see which of your patients are entitled to free vaccines. And the other change that came in is that Pneumovax 23 is now only limited to 2 lifetime doses. So it used to be 3 doses in adult lifetime, and now it's 2 lifetime doses. Children under 12 months of age, no change except for those with risk conditions. And well, that's not really a change. We've always done additional doses for those children with at-risk conditions. And that's the Prevnar 13 that we do at 6 months of age. And then they get Pneumovax 23 at 4 years of age, and then Pneumovax, their second and final dose of Pneumovax 23 at 5 years or later after that. You know, recommendations change all the time. At this stage, those are the 2, that's all the doses of Pneumovax 23 they're able to get. Anyone over 12 months of age, they get the Prevnar 13 at diagnosis. Then they get the dose 1 of Pneumovax 23 2 to 12 months later, or over 4 years of age, whichever's later. And then the additional dose and final dose of Pneumovax 23 at least 5 years after that. And that is it for lifetime dosages. Aboriginal and Torres Strait Islanders, they get a Prevnar 13 when they turn 50, and then 2 to 12 months later, Pneumovax 23, and then their final dose 5 years after that. So the schedules for anyone who's at risk are all essentially the same now. We used to have differing schedules. We had the Prevnar 13 and then 3 Pneumovax 23s used to. For one risk condition, and for another risk condition, they had just had the Pneumovax 23. So now everyone with a risk condition gets the same schedule. So it has reduced the complexity quite a bit. If someone's previously received a Pneumovax 23, they should still get that Prevnar 13. So just making sure that you leave 12 months between them. If you give Prevnar 13 first, then you only have to wait 2 months until the Pneumovax 23. However, if they've had the Pneumovax 23 first, you have to wait 12 months before you can give the Prevnar 13. Anyone over 70 years of age who doesn't have a medical risk condition get the Prevnar 13 at 70 years of age, and then that's it. There's no time limited catch up on that. So anyone who turned over 70 on the 1st of July 2020 or is over 70 on that date, they're eligible for that funded dose. So if you've got an 80-year-old that had their 65 dose, a healthy 80-year-old that had their 65-year-old dose of Pneumovax 23 back in the day, then you'd be wanting to give them a Prevnar 13 now. The Haemophilus influenza type B is a single dose, and that's funded for asthenia and hyposthenia patients over 5 years of age. So we do HIB in the childhood schedule, so it's only required for those over 5 years of age. We don't do HIB catch-up beyond 5 years unless somebody has a medical risk condition, and asthenia and hyposthenia is one of those. It's just a single dose, and at this stage boosters aren't required. Still recommended for people who've had a hematopoietic stem cell transplant. However, it's not funded with the NIP. All right, so just a question that we occasionally hear, which we bandy the word around quite a lot, is what is a TAGI? And a TAGI is the Australian Technical Advisory Group on Immunisation. And that is a group of immunology specialists who advise the Minister on the NIP and immunisation related issues. They're our peak body and our peak advisory body on immunisation. They also provide advice for research organisations, so the National Centre for Immunisation Research and Surveillance, for where research needs to be focused, and they provide advice on the vaccine effectiveness and use in Australia. So they meet quite regularly and review vaccines and how effective they're being, and provide advice on those. So they're very involved in the influenza vaccine annually and the advice that comes out there. They are also involved in the consultation for the immunisation handbook, the Australian Immunisation Handbook, which you'd all be very familiar with. And they are a consulting body for organisations who are implementing immunisation policies, procedures and vaccine safety. So they're a very knowledgeable group, and as I said, the peak body when it comes to anything immunisation related. And whenever we tell you follow the ATAGI advice, that's what we mean. Okay, so moving on to vaccine preventable diseases.
Just before you go there, sorry to interrupt.
Sorry, I should have stopped.
It's all right. I've got a question on Pneumovax. So, and I'm not sure if you've answered this. So an adult with at-risk condition given Pneumovax 23 first needs to wait 12 months for Prevnar 13. Do they need another Pneumovax 23 at 5 years?
Yes. So when you've got anyone who's had an incomplete or partial pneumococcal course for a risk condition, you need to do catch up for them. So you would give them, depending on when you catch them, but let's say theoretically they've come to you 4 years after they had their first Pneumovax 23, you'd give them a Prevnar 13 now, and then 2 to 12 months later, you would give them their second and final dose of Pneumovax 23. So it's a lot easier to understand when you're doing the catch up. Basically, if somebody's had has a risk condition, it's Prevnar 13, then it's 2 to 12 months later, it's dose 1 Pneumovax 23, and 5 years after that, it's dose 2 and final dose of Pneumovax 23. And then depending on what the person's had when they've come to you, you work your catch up around that, but it's pretty simple and straightforward. Was there anything else?
There's one on Zostavax, as we're talking about 70-year-olds. From November this year, the Zostavax is only funded for 70 years. Does that mean before their 71st birthday?
Yes, it does. So from the day they turn 70 till their 71st birthday is when they're funded for that vaccine. Okay, so just moving on to vaccine preventable diseases, which I usually cover for anything that is topical, which we all know what's topical currently. So if I want to sum up what's going on in that sphere, this slide would just sum it all up. If you're anything but COVID, basically this is where you're trending. So I'll quickly go over some of the more regular vaccine preventable diseases that we cover, just so you can see how things are going. Pertussis, you will all be very familiar with, whooping cough. You would know that it normally comes in peaks and troughs and is a recurrent issue. Well, you can see since COVID came to town, pertussis has it's gone into hiding. So the social distancing, the mask wearing has had a big effect on the rates of pertussis in the community. It is still circulating, it's not completely gone, but nowhere near the levels that we'd see, the peaks that we would see every 3 to 4 years with the waning of the vaccine. So yeah, it's amazing to see that you can basically see, we had, I think, our first case of COVID in about January 2020, and it started going off around March, April, and you can just see a complete drop in cases as we're isolating and going into lockdown, and it hasn't come back. The strategies that we do to control it, we're still vaccinating in our primary courses at 6 weeks, 4 months and 6 months. We do boostering at 18 months, 4 years, and in the adolescent program, we have maternal vaccination, and everybody else who is at risk of contracting and transmitting every 10 years, the current recommendations. That still hasn't changed. Healthcare workers included every 10 years. And measles, another one that we used to see lots and lots of. We shut our borders, and you can see we've had no cases of measles. Measles hasn't been endemic in Australia for quite a while. So these cases that we saw were always imported from overseas. But since our borders have closed, we've seen no cases of measles. So it's had a nice flow-on effect there. Don't know about you, I'd take measles back any day. Immunisation control strategies for that. There are 2 funded doses that we do at 12 months and 18 months on the NIP for kids. Anyone born on or after 1966 can get free MMR vaccines, and rubella seronegative postnatal women get free vaccines. And in special circumstances, we do early vaccination, which we were doing way back when, before COVID, we had a bit of a measles outbreak, and we were bringing those vaccinations early, but obviously that's not an issue now, so we don't need to bring forward our 12-month vaccinations. In Australia, 94.1% of 2-year-olds are vaccinated for measles, which is pretty good. We're getting closer and closer to that 95% golden figure, which is the figure that we want the population to be vaccinated at to provide a benefit to the entire community. Meningococcal, that has improved, but it hasn't gone away. You can see we still have a few cases, nothing compared to how things were pre-pandemic. Meningococcal requires close, prolonged, intimate type contact. So the wearing of masks and social distancing has a little bit of a difference, but it is still circulating, and people are still contracting it. So the black line is the B strain, and you can see that that is the most prevalent out there. We've seen a drop in the W and the Y. So the yellow line are total combined of the strains. There's 4 strains. B is by far the most prevalent. And I always like to show this because this is the meningococcal C, and it's very, very rare these days to see meningococcal C because of our vaccination program. Meningococcal C used to be the most prevalent meningococcal strain out there, way more prevalent than any of the strains we see today. And so it's just a good demonstration of what a vaccination program will do. As control strategies, we between 2003 and 2018, we've been vaccinating for meningococcal C at 12 months. In 2017, we brought in the 4-valent into the adolescent program, and in 2018, we added that to the childhood program at 12 months. And then there was the addition of the meningococcal B for Aboriginal children under 2 and people with risk medical conditions. So, you know, watch this space. There may be, there's been a lot of change and addition in the meningococcal immunisation field, so there may be yet to come. The funded groups for MenACWY, obviously for children at 12 months of age on the schedule. We do catch up if they haven't had a meningococcal C vaccine before. So they're under 10 and they've come to you completely unvaccinated for any strains of meningococcal, then you can catch them up for MenACWY. If they've already had a Men C vaccine, there's no funded catch-up for MenACWY. It's funded for adolescents 15 to 19 years of age, which we do in the school program, and also the risk medical conditions that I've been through. So if you've got a child between 10 and 15 who hasn't had a meningococcal vaccine yet, you would give them a meningococcal C, so a monovalent Men C, which is the NESVAC C, because it's not funded in those age groups for the 10 to 14-year-olds. They'll get their adolescent dose at 15 to 19 years. Is there any questions you wanted to throw in there, Sandra?
There's a couple of timing questions. How long can you delay a scheduled vaccine? For example, 6-week-old baby who can't get the vaccine due to lockdown.
Well, the vaccines are considered an essential service, and that's something that I'll go over shortly, but we shouldn't be putting off delaying vaccines. It's a very important initiative, and it's considered an essential service. So people are allowed to leave their home quarantines to go to their GP appointments to get their vaccines.
There's a similar one with the 4-year-old, same but different. Parents turning up a few days or weeks before 4 years of age and preferring to have it as the blue book. The blue book still says 3.5 to 4 years.
Yeah. Well, you can still give it that little bit earlier. We do prefer that you stick to the schedule points, though. So the parents just need to be explained that you know, their book is out of date and the recommendations have changed. We do a booster at 18 months for the diphtheria, tetanus, pertussis. There's no need to bring it forward. The only reason we ever brought it forward to 3.5 was for that breakthrough ilk disease that we were seeing. But having added that at 18 months, it's much better to have it at the 4 years, because their next vaccine is not until they're adolescents, and we want to make sure that they're getting maximal benefit from these vaccines. So I would discourage them from coming in early. You know, obviously if somebody's fronted up because there's been a bit of a mix up with the vaccine appointment and accidentally came in a couple of days early, then there's no major harm there, but I would not be encouraging people to come in early.
And on Bexsero, if a child has had Bexsero as a child, do they have immunity in adolescence? No. So all of the meningococcal vaccines wane, immunity will wane. We tend to say you're good for 5 years. I mean, Bexsero is a relatively new one, so that one's still being, you know, observed and researched, but so there's no current advice with Bexsero for boostering. At this stage, I would think with all of the other, with ACWY and your other Men Cs, the advice is that if you're going to a meningococcal endemic area, you should get boosted every 5 years. Because of the waning immunity. With the adolescents, we time it at that 15 to 19 year period, because and get them at year 10, and then that will cover them for that higher risk period. But I would think the B is probably the same, but like I said, they're still that's only been around for a couple of years, so they'll still be doing longevity studies on it to see how long immunity lasts for, but I wouldn't rely on it being protective. But there's no current advice to booster. And an interesting question, and I'm assuming it refers to NIP vaccines. Would it be possible to give a a vaccine to a non-eligible person if it's going to expire rather than throw it away?
Yeah, I don't have a problem with it. Yeah, I mean, yeah, I mean, I'm not, yeah, I mean, I'm all about using resources effectively, and I don't see why not. Yeah. Anything else?
There's one here, I'll try and read this. It's from Alison. She may like to type it again if I get this wrong. If someone goes against the recommendations and checks the serology of a patient with 2 documented MMR vaccines, but comes back negative, I'm assuming the question is, do they or do they not get a funded vaccine?
Look, yeah. Technically no, but just give it to them. It's, you know, it's funded for anyone over born on or after 1966. So I wouldn't be quibbling about it. We shouldn't be checking serology for post-vaccination serology unless, you know, you've got a high risk group. So, you know, unless it's a woman who's planning pregnancy, you just don't routinely check serology, post-vaccination serology. They're notoriously inaccurate, so they'll give false negatives. So people probably are immune, but you do have to act on that result. So you do, you know, if somebody has had a test done, you can't just leave it as non-immune. So you give them that booster and then don't test again. So yeah, look, you know, it's through no fault of their own that that happened. So yeah, sure, give them a vaccine. All right, I'll move on to the next section. So hepatitis B, it's another one that they like us to cover, and that is a disease that causes significant worldwide issues. It's estimated that over 350 million people worldwide have chronic infection from hepatitis B. More than 1/3 of the world's population is infected with it. And we see more than 1 million deaths worldwide every year. In Australia, we're pretty lucky. We see lots of cases, but it's not too bad compared to other countries. In New South Wales, about 2,000 are newly diagnosed every year, and we have approximately 230,000 with chronic infection in Australia. So it's not insignificant, it's not huge, but still a lot of people that are affected by hepatitis B. So we have a control strategy, which is the birth dose, which we give to offer parents of all newborns the birth dose that's given within the first 7 days of life. And in Northern Sydney, we have a 95% uptake of that, which is great. It'd be great if we could have more. There's pockets of areas where people don't have a great understanding of why we do this. And so we do see some lower rates, but 95 is pretty good. We don't catch it up, so if it's not given in those first 7 days, we don't worry about it. It's not counted as part of the vaccines that are required for no jab, no pay and play. And the reason we give it is to protect the for vertical and horizontal transmission. So we want to protect the potential transmission from mother to baby during the birthing process, and horizontal transmission being anybody else, usually household contacts, so people that are living closely with the baby. It primes B cell memory in readiness for the next 3 doses at 6 weeks, 4 months and 6 months. So it makes the uptake from those vaccines and the immune response a lot more rapid, having had that initial dose at birth. The first, second and third doses given at 6 weeks, 4 months and 6 months as per schedule. I've repeated myself, 96.5% at 12 months in Northern Sydney. I must have gone wild with my copy and paste there. And mothers who are hepatitis B positive, we have additional follow-up with those babies. So they're given immunoglobulin within 12 hours of birth, plus the birth dose of vaccine, which everybody gets. And for babies born to hepatitis B positive mothers, we have 100% uptake of that, which is great. So we have 100% of babies are given that immunoglobulin within 12 hours of birth, and plus the vaccine. And then they go on to have a normal schedule as per everyone else. And at the public health unit, we follow up the mums and the babies. We talk to the mums about the timeliness of vaccination. We make sure that they're aware that their hepatitis B antigens and antibodies should be checked at 3 to 12 months after they've finished their course of vaccine, and not before 9 months of age. So we don't do it any earlier than that, because the immunoglobulin given at birth can affect that result. The importance of early protection, the reason that we do it so soon is, in essence, that if you're infected as an infant, you're usually going to be asymptomatic. So you'll usually not be suspected of having infection, and the disease is usually persistent. And the likelihood of chronic infection and advanced liver disease is 90% if you're infected as an infant, and 30% if you're infected as a child. And then the older you get, the less likely that you will develop that chronic infection. So by way of example, adults are only 5 to 10% likely to develop chronic infection when infected as an adult. And they're more likely to be symptomatic, so disease would be suspected and investigated and treated, as opposed to asymptomatic infants, where it can be quite insidious. So it's really important to make sure that these neonates are getting this birth dose of vaccine, and that's something that I encourage maternity services to make sure that they're letting the parents know that's why we do it. There's a lot of misinformation and misunderstanding from parents about why we're doing it so early. They don't think that their child, they don't understand why we're worrying about what they see as a sexually transmitted disease, or a disease that you get from using dirty needles, why we're giving that to these little infants. But that's why we do it. We make sure they're protected now, so that if they do get infected, they're less likely to have chronic illness. Okay, so
question on the immunoglobulin in regards to the Hep B immunoglobulin routine time frame. Is that the same in the extreme premature infant cohort as well?
Yeah, it depends. It's up to the treating specialist, to determine whether or not yes, it is. If the treating specialist has determined that they're medically stable and able to receive it, but it's ultimately up to them. So we've now got mandatory reporting of birth doses. From the 1st of July, all vaccinations are mandatory to be reported to the Australian Immunisation Register within 10 working days. So that's any NIP vaccines have to be reported to AIR, and that includes the birth dose. So immunisation providers need to register for a PROTA account to access AIR, and that includes to report vaccinations for new patients that don't have a Medicare number. So such as babies or anyone from overseas that doesn't have a Medicare number, those immunisations still need to be reported to AIR. Those that don't have a Medicare number can still have those vaccinations, and you can report them to AIR using existing practice software, or you can do it directly on the secure site. Okay, moving on to influenza. That is, you'd all know, we haven't really seen much of that either. We really haven't seen a significant flu season since 2019. So the statistics I have are a bit old. They go back to 2019. And back then we were seeing about 300,000 laboratory confirmed cases, and it's thought that we have over 800 associated deaths, mostly in the aged population. The crude case fatality rate for influenza in Australia is 0.1%. And you compare that to COVID, which is currently 2.1%. Influenza is nothing compared to COVID. It is COVID's far more likely to kill. We've seen, as I said, minimal cases in 2020-21, and we've had no recorded deaths since July 2020, which is unheard of. We control influenza with vaccination of everybody over 6 months of age. So regardless of pre-existing medical conditions, everyone, fit and healthy or not, we should be recommending influenza vaccination. We give it for free for risk groups. So those are children, the over 6 months to under 5-year-olds, the over 65s, pregnant women, Aboriginal and Torres Strait Islanders, and anyone over 6 months that has a risk medical condition. And then we also have the over 65 high dose formulations. The quadrivalent vaccine, they're all quadrivalent these days. They always have a 2As and 2Bs. These are the strains that we have this year in the 2021 formulation. And they're based on what's been happening in the Northern Hemisphere before it comes through to us. Looking at notifications, you can see this was 2017. You may remember back in 2018, we had a nice little rest. And then 19 was another bit of a horror season. So A is the black line, B strains are the green line. And then again, we saw COVID come to town. We all went into isolation, and we have effectively not seen much influenza at all since then. So another flow-on effect of social distancing, hand washing, cough etiquette, wearing masks, all of those things. Just pointing out the ATAGI guidance for influenza that comes out every year for in preparation for the flu season, and this is just a table from there. It's an easy to refer to table on what vaccines are out there and what age groups they're registered for. But there's lots of information in that entire document to do with anything flu vaccine related. All right, so going on to shingles.
Sally,
yep, sorry.
That's quite all right. And so we've got a flurry of questions on reporting, but we'll come to that a bit later. Yep. There's one here, keen to understand the rules and advisories regarding mandating flu vaccine in healthcare facilities. The NHMRC guidelines seem open to interpretation for only high-risk areas. Are you able to advise for community NGO staff who work with rural communities, etc.?
Well, being a New South Wales Health employee, we're governed by New South Wales Health documents and policies. And so our occupational health assessment and screening against vaccine-preventable diseases policy document has risk conditions where influenza is mandated, and that's category A high-risk positions. So not all New South Wales Health staff are required to have influenza vaccination. The aged care facilities last year, it was mandatory to have influenza vaccination. This year, it is highly encouraged. I can't remember if it ended up being mandatorily implemented this year with all the COVID stuff that was going on, but that was a Commonwealth decision, so Commonwealth responsible for aged care facilities. So that is governed by the Commonwealth. So in New South Wales Health facilities, if you work in a high-risk area, so that is NICUs and the ICUs, and some other areas that escape my mind, that they're category A high risk, and they are required to be vaccinated. As far as it goes for NGOs and other organisations, I would just, there's not much governance. I suggest people refer to the New South Wales Health policy. I mean, that is a peak an ideal recommendation for anyone working in healthcare as to what vaccination, immunisation protection needs to be provided, and that is where I would suggest that is the document I would suggest you use. But at the end of the day, there's no mandate for it currently. Did that answer that or not? Was there anything else, Sandra?
Not on influenza, as I say, lots of questions on reporting, but we might fit those in a bit later.
Sure. So just going on to Zoster, because there's been a couple of changes there. That's caused by the reactivation from a chickenpox virus. So you can't get shingles without having had chickenpox first. So it's estimated that over 97% of people aged over 35 years have had prior infection. So that's a significant amount of people. And those are the people that were too old to have got a varicella vaccination. So that's a significant amount of people that have been exposed to chickenpox who are at risk of reactivating and having shingles. It can lead to severe nerve pain, serious eye problems, including blindness, pneumonia, hearing problems, swelling of the brain, and even death. Approximately 1 in 3 people who have been infected with chickenpox will develop shingles if they haven't been vaccinated with Zoster vaccine. Post-herpetic neuralgia is diagnosed if the pain from the shingles is persisting for more than 3 months. And post-herpetic neuralgia occurs in 25% of all cases over the age of 80. So it causes significant morbidity and amongst those groups. It affects lifestyle, lots of pain and discomfort, and can be quite disfiguring. So it's a significant issue. So the strategy that we have in place is that we have the Zostavax, which is funded for 70-year-olds. The catch-up ends on the 31st of October this year. So that catch-up's been going for 5 years at the end of that date. And that is for 71 to 79-year-olds. So if you've got anyone at your practice that hasn't availed themselves of that vaccine yet, it might be worthwhile doing some recalls before that funding ends at the end of this year. Studies have shown that people who are vaccinated over the age of 60 years, it will reduce the incidence of Zoster by about 50+%. The incidence of post-herpetic neuralgia by 66+%. And the burden of illness associated with Zoster by over 60%. So it does provide a significant relief. And anyone who does still develop the illness, having been vaccinated, they're much less likely to have severe symptoms from it. So not quite as bad rashes and pain and disfigurement. So the Zostavax vaccine that we give on the schedule, that's a live attenuated vaccine. It's 14 times the dose of the chickenpox vaccine that we give kids. It's licensed for use in 50 years and over, and there's a single dose. There's no recommendations for boosters currently, but watch this space. As we all know, vaccine development is constantly improving and changing, so that may change, but currently it's a single dose. As a live vaccine, there is a risk of disseminated varicella zoster virus replication if it's given to someone who's significantly immunocompromised. And so that is, you've got, with a live vaccine, you're giving people a weakened version of the virus. So it's not dead, it's just weakened. If someone has a compromised immune system, even that weakened virus is too much for them and they can't fight it. And it becomes disseminated and can kill them, and we've seen 3 fatalities since the introduction of this vaccine, and that was specifically in people who were given a live vaccine with immunocompromising conditions. So it's really, really important to make sure that they're properly screened before they're prescribed these vaccines. And anyone who has any kind of immunocompromise shouldn't be given them. I don't expect you to be able to read this, but this is in the handbook. So it's a table for the recommendations for the use of zoster in people who are on immunosuppressive therapy. So it's a good guide to refer to if you've got somebody on certain doses of immunosuppressive therapy. It will tell you what is safe and what isn't to give the vaccine in. And so that's in the handbook, links on it on the bottom of the slide. And there's also the screening tool, which is really important. Each patient who you're assessing for these vaccines, you should go through this screening tool with them. This is in the handbook as well. And there's also, I understand, versions that have and can be incorporated into practice software. But very important, they ask those prompt for those questions to ascertain whether it's appropriate to give this vaccine to that individual. So if you don't have it or are not aware of it, I suggest you make sure you're using that for everyone before you're giving this vaccine. And you'd all be aware that we now have a new contender in the market, which is Shingrix, and that's a recombinant vaccine. So it's an inactive vaccine, it's not live. It's is licensed for use in people 50 years and over, and that's given as a 2-dose course 6 months apart. Studies have shown it's 91+% effective against herpes zoster in 70 and over, and 88+ effective for reducing the risk of postherpetic neuralgia in the same age group. So it's quite an effective vaccine. It's currently only available on private script. I don't know if it will ever be included in the NIP. That would be up to the vaccine company to take it to ATAGI and the PBAC, the Pharmaceutical Benefits Advisory Committee, and they will make a decision as to whether or not there is a benefit to the population to add that vaccine. It certainly opens it up for those groups of people who can't have a live vaccine. So it does give them additional options. Unfortunately, it's not funded. Okay, any other questions before we hit COVID?
Yes, there's a couple on shingles. If someone has had shingles, can they still get the vaccine?
Yes, they can, but you need to wait a year after infection. So once their acute illness has passed, a year needs to pass before you can give them that zoster vaccine. And it's recommended, in fact, because while obviously you're not using it as a treatment, it will, and it's also rare that you'll get repeat cases of zoster. Any repeat cases that you do get will be much less severe having had the vaccine.
And another one, if someone has not been vaccinated for chickenpox and has never had it, what are their chances of developing shingles?
So not been vaccinated, never had it. So if you're in an older age group, you are probably likely to get it because you probably thought you've never had chickenpox but actually did. It's not unusual for people to have very, very mild subclinical type cases, and so we're never really aware that they had chickenpox in the first place. If you have absolutely not had chickenpox, it's impossible to get shingles. You have to have had initial infection with the varicella virus for it to then go dormant and then be reactivated as herpes zoster. So if you're someone who thought you've never had chickenpox but then you got shingles, you would have had chickenpox, you just didn't realise it, or your mum may not have realised it at the time because you only had 1 or 2 lesions.
If 97% of people over 35 will get shingles, why is Zostavax not funded until over 70? And can you pay for one if you're over 35?
Sorry, say that again.
If 97% of people over 35 will get shingles, why is Zostavax not funded until over 70? And can you pay for one if you're over 35?
So 97% of people over 35 have been infected with the varicella virus. Not 97% will get shingles. So 1 in 3, I think they were saying before, will develop zoster. So 97% of people have had chickenpox is what I was saying in that slide. It is most prevalent in the plus 50-year-olds, so that's why it's not registered earlier than that age. So no, you wouldn't give it to anyone under 50. It's not registered for under 50-year-olds. You can give it for 50-year-olds. That has to be privately funded. The only time it's funded is at 70. And the reason we give it at at 70 is because when they looked at the benefits from the vaccine to the population, the best benefit was in that age group. So they were more likely to have complications after getting shingles, so the post-herpetic neuralgias, and the severity of the disease was greater in those age groups. So that's why they've funded it only for that age.
A couple more. So people who come back for Zostavax after the 31st of October and they're already 71 or over, can we not administer Zostavax to them? Would they need to buy it privately? And if they don't, they're going to be at risk.
Well, yeah, basically they're not funded and they shouldn't be getting it. I mean, if you're going to ask me that question, I'll tell you the rule of the law. If they're over that age, they need to pay for it privately.
And what's the funded age for Zostavax when the catch-up finishes?
70. So from the day they turn 70 to the day before they turn 71.
Immunocompromised people can get the second vaccine. I'm assuming they mean Shingrix, but it's not free.
Yes, that's right. So it's a privately funded vaccine, but it gives options to people who can't have a live vaccine and wish to prevent the likelihood of developing shingles and post-herpetic neuralgia. Yes, it's an inactive vaccine, so it can be given to people with immunocompromise.
And finally, on Zostavax, for Zostavax in some other countries, the full course of Zostavax vaccination is 2 doses. If someone wants to receive this vaccine earlier with the full course, what is the number of doses recommended in Australia, and what is the interval in between?
So there is no recommendation for any more than 1 dose of Zostavax vaccine. Was that the question? Zostavax?
Yes.
Yeah. So there's the recommendation in Australia is 1 dose. So you wouldn't be, even if it's privately funded, you wouldn't be prescribing it. It's not, the ATAGI guidelines are that a single dose is adequate protection.
All right. Well, I think that's all for Zostavax at the moment. We've got a random selection of other ones and we'll try and fit them in towards the end.
Sure. All right. So on to COVID, which is occupying all of our lives way more than it should be. So just a quick recap. We first saw it in January 2020. And to date, today, these are up to date today, we've had over 44,000 cases in Australia and 984 deaths, which equates currently to a 2.2% crude case fatality. So that's of all the cases, how many people are likely to die. So if you contract the virus, this percentage, 2.2%, are likely to die from it. Globally, we've seen over 212 million cases and over 4.4 million deaths, and that's a 2.1% crude case fatality rate. So we're kind of on par. We were, after Victoria's outbreak last year, we were at a 3% crude case fatality rate because of the amount of deaths that we saw with it being in the aged care population in the aged care facilities. So it increased our crude case fatality rate, but that's starting to come down now with this latest outbreak. So looking at this graph, it is just basically a, I can't even read it, sorry, my banner's in the way. That is a graph of, now I've got to look like old lady. Total number of cases in Australia reported each day. So those, you can see the outbreaks that we've had, and we've been ticking along nicely here. And then this is our latest outbreak, and seems to be continuing in an upward trend. The cases that we see by age and sex, you can see that the more likely age group to contract COVID are the younger, the 20 to 29, 30 to 39 year age groups, much more likely. We still see it in kids, but the transmission rate's nowhere near as much as this group. These are the groups that are socialising and travelling around, working, commuting. So you're much more likely to see it in those groups. And then it reduces as you get older. However, if you look at the deaths, the opposite of that is true. So the older you get, the more likely you'll die from COVID, and that's reflected in those ages by death charts. So those groups that are much more likely to contract it are much less likely to die from it. So that's why, you know, vaccinating this group and protecting everyone around these groups are really important. And it's also very important to get these groups vaccinated too, which fortunately we're going to start to do, so that we can protect everybody else. So these are cases in aged care facilities by state. So in Australia, you can see the yellow bar is deaths from contracting COVID in aged care. And you can see the huge amount that Victoria had in their outbreak. Unfortunately, they had significant numbers in their aged care facilities, which saw a significant amount of deaths. You can see in New South Wales, we've had a few outbreaks, but touch wood, fortunately, we've been able to control any outbreaks that we've had in our facilities. So yeah, that's evidence of what happens if aged care facilities have an outbreak. So it's hugely important to make sure that they're protected. These are the cases that are in ICUs currently. So Australia-wide, you can see New South Wales is leading with our current outbreak, particularly in Sydney. We have quite a lot of cases and quite a few in ICU in the yellow. And then you can see that it places an increased burden on our healthcare system. The control strategies, we've got the AstraZeneca vaccine. That's the non-replicating viral vector vaccine. That's been shown to be 70% effective in clinical trials and 100% effective against severe disease. So if you 70% effective in preventing illness, contracting it, and 100% effective against severe disease. So even if you are unfortunate enough to contract it, you are much less likely to be very adversely affected by it. It's provisionally registered for the 18 years and over, and each vial has 10 doses of 0.5 mils. It's given in 2 IMI injections into the deltoid. The recommendations are 4 to 12 weeks apart. Currently, because of, in an ideal world, you'd stick to those 12-week intervals, but in outbreak situations, we're wanting to get people vaccinated sooner. So we say 6 to 8 weeks. The minimum interval is 4, so you can bring it forward to 4 if people are particularly keen to get vaccinated. But the further apart, the more effective it is. If it's given too early or it's given too late, there's no indication to do any additional doses. It's not interchangeable, so it's not a routinely interchangeable thing. We do interchange it in special circumstances, but none of the COVID vaccines are routinely interchangeable with each other. It's stored at 2 to 8 degrees Celsius, so just through normal cold chain. After it's opened, you need to discard it when it's been kept at 6 hours at room temperature, or 48 hours at 2 to 8 degrees. So it gives you a little bit more play once you've opened and reconstituted it. The thrombotic thrombocytopenia syndrome following the AstraZeneca vaccine is a very well-known side effect from the AstraZeneca vaccine. It's also known as VIT and VIPIT. They haven't settled on a choice term for it yet, but those are all interchangeable terms. They all essentially mean the same thing. It's a very rare and newly identified condition, and that's associated with AstraZeneca and the Johnson & Johnson vaccines. So current estimates are that about 1 to 2 people per 100,000 who receive the vaccine will develop this. Those that are under 60 years of age, it's estimated to be 2 to 3 per 100,000 people. So the older you get, the less likelier it is. The younger you are, the more likely that you'll develop this. So who's at risk? Well, there aren't any pre-existing medical conditions that have been identified yet that contribute to your risk. There's theoretical concerns about a few rare conditions, so the cerebral venous sinus thrombosis, the heparin-induced thrombocytopenia, idiopathic splenic thrombosis, and the antiphospholipid syndrome with thrombosis. Those have similar traits to TTS. And so there is some theoretical concern that there may be an increased risk in those patients. So if you've got somebody with those history of those conditions, the preferred vaccine is Pfizer. The symptoms are things like really any kind of thromboembolic event, so persistent headaches, with or without vision changes. So when I say persistent headaches, they're severe headaches that aren't resolved with simple analgesia, so persistent and severe, and Panadol and Nurofen doesn't touch them. Any kind of focal neurological issues, seizure-like activities or coma, abdominal pain, leg swelling or pain with or without colour changes and coldness, chest pain and or shortness of breath without a clear alternative cause, and petechiae or unusual bleeding or bruising. So any of those things could potentially clinically indicate this syndrome when given close to an AstraZeneca vaccine. So the onset of symptoms are usually 4 to 42 days after vaccine. And they have a thrombosis, so any kind of thrombotic event, not just the cerebral venous sinus or the splenic vein. It can be DVTs, PEs, any kind of thrombosis with thrombocytopenia and with an elevated D-dimer, so usually ×5 the upper limit of normal. The control strategy for the messenger RNA vaccine, so you'd all be very familiar with Pfizer, which is the other vaccine we currently have on the market. That's been shown to be 95% effective in clinical trials after 2 doses. that has been provisionally registered for 12 years and over, and each vial contains 6 doses of 0.3 mils. That's again another 2 IMI doses at 21 days apart. The minimum interval is 19 days, and the course should be completed within 6 weeks. There is a bit of variation around the timing with that, with the demand for the doses. So you can give it, you know, you can give it, delay it is what I'm saying. You don't have to give it snack on the 21 days. You can give it a little bit later, but you should be completing the course within 6 weeks. If there's any variation, too late, too early, there's no indication to give any extra doses. And again, it's not routinely interchangeable. That can be stored for 6 months at the -90 to -60 degrees temperatures, 1 month at normal cold chain, 2 to 8 degrees. 12 hours of that has to be can be used for transportation. So if you're transporting your community, however you say it, at any time for that 1 month period, only 12 hours of that can be used to transport the vaccine. And it can be stored for up to 2 hours at temperatures up to 30 degrees Celsius. After it's been diluted, it should be discarded after 6 hours. Moderna, which is the other messenger RNA vaccine that you would have heard of, that's coming to town. That's been shown to be 94.1% effective for preventing illness and 100% effective for preventing severe disease. And that, again, a 2-dose course, and that's provisionally registered for 18 years and over. Each vial has 10 doses of 0.5 mils, and those 2 doses are given 4 to 6 weeks apart. Again, not interchangeable, and we're expecting to get quite a few million doses at the end of September. So that will, we'll get more information about that as that's added to the rota of vaccines, but it will be good that we've got some more options available to us. That can be stored at -25 to -15, which is just standard freezer temperatures. Unopened vials can be thawed and stored at 2 to 8 degrees for up to 30 days. Open vials at 2 to 25 degrees for 19 hours, and then they need to be discarded. And it cannot be refrozen. So the risk of pericarditis and myocarditis with the messenger RNA vaccines, this is another adverse event that we've become aware of, with which you don't hear so much about as you do with the AstraZeneca's adverse events. But the risk of myocarditis and pericarditis, particularly in young males, and particularly after the 2nd dose, it's not uncommon. We see it quite a bit. It's usually mild and the recovery is quick. Symptoms typically occur within 1 to 5 days of vaccination. Most pre-existing cardiac conditions aren't regarded as a contraindication to the vaccine. So if they've had any other heart problems in the past, it's not a reason not to give the vaccine. If they've had a history of myocarditis or pericarditis in the last 6 months, you should be deferring vaccination. If they've had a history of either greater than 6 months ago, then they can be vaccinated, and it is recommended that they still get that vaccine. But if they have had it earlier, like within the last 6 months, do not give the Pfizer vaccine. Cases following the 1st dose. So if you have a patient who has had their 1st dose and they've developed myocarditis or pericarditis, then the recommendation is to defer it and then either consult with a specialist cardiologist, or you can make that decision yourself as to whether or not to go ahead with further doses. So timing with other vaccines, it's not recommended to give on the same day with any other vaccine, only because there's no data on it just yet, but it also makes it difficult to attribute where the adverse event came from if you're giving multiple vaccines on the same day. So the preferred interval is currently 7 days between any of the COVID vaccines and any other vaccine. A shorter interval is acceptable in certain circumstances. So if there's an increased risk of COVID, somebody contracting COVID-19 or another vaccine preventable disease. So in an outbreak setting, or if you've got somebody who's had a say they've had a tetanus-prone wound, you wouldn't worry about your intervals there. You'd give them when they needed to be given. And also, if there's logistical issues, you can shorten the intervals, but I wouldn't make it a routine habit. But if there's no other time that you're able to schedule the vaccine, then you can give it a bit sooner. If they are accidentally given together, there's no need to repeat it, but you should let the patients know that adverse events are more likely. So they're more likely to have a, not severe adverse events, but those usual common adverse events that you get after receiving a vaccination. Vaccinating someone with a past history of COVID is not a contraindication. It's recommended to defer if somebody has had a PCR confirmed case in the last 6 months. So if 6 months since illness, acute illness has passed, then they can get vaccinated, but we recommend that it's deferred if they've been unwell sooner than 6 months. There's no specific safety issues with it that has been identified in trials. Testing to detect there's no specific safety issues that have been detected now that it has been well and truly outside of trials either. There's millions of people in the world that have been infected with COVID that have received the vaccine, and there haven't been any safety issues identified. Testing to detect current or previous infection is not recommended, so you would give it regardless. If somebody reported an illness and they didn't have it confirmed, COVID confirmed on PCR, then you would still give it. Don't worry about doing testing. Vaccinating children. So we're currently recommending vaccination for children aged 12 to 15 if they have specific medical conditions that increase their risk, if they're Aboriginal or Torres Strait Islander, or if they're living in remote communities. They're not registered or recommended for use in children under 12 years of age. There's no safety or efficacy data yet. That hasn't been, they're doing some studies, but their study findings haven't come out yet. So it's thought that eventually it will broaden in age groups, but currently not for under 12s. Healthy children have a much lower risk of severe illness compared to adults, but as I said, that guidance may change. Vaccinating pregnant and breastfeeding women. So pregnant women are at an increased risk of severe illness and complications and adverse outcomes. So they should be routinely offered Comirnaty. So that's the messenger RNA vaccine at any stage of pregnancy. Women who are breastfeeding or planning pregnancy are also recommended to receive Comirnaty. There's limited data on the safety of viral vector vaccines in pregnancy, which i.e. AstraZeneca, so that isn't recommended or preferred vaccine in pregnancy. Vaccinating the immunocompromised, very important. They're at a much greater risk of complications, having contracted COVID. So it's recommended in those groups. There's not a lot of safety data available because they were mostly excluded from clinical trials, but there are no theoretical concerns with it. They're not live vaccines. There is, however, possibility that the efficacy of the vaccines may be reduced because of their impaired immune systems. So patients who are immune compromised, while very important that they're getting vaccinated, they should be counselled on the possibility that it may not be as effective. And so it's very important that they continue to use other protective measures. And just a plug for maintaining routine immunisation services during the COVID-19 pandemic, which we touched on before when I answered one of the questions. ATAGI, New South Wales Health, have been very clear that it is essential that we continue these services during the pandemic. Delaying immunisation is puts people at risk of, the population at risk of having a resurgence of other previously well-controlled vaccine preventable diseases. And that will just put further strain on the healthcare system, which we don't need. So we've got great rates of vaccination. We've worked really hard. You guys have worked really hard to get there, to get people vaccinated. So it's really important that we maintain those, so that we've got as strong a population as possible while we're facing this pandemic. Recording doses. I've mentioned before, every dose needs to be recorded on air. It's mandatory. It helps us to monitor coverage, ensures that we're giving the right vaccines at the right intervals, and it most importantly for everyone out there, it's providing proof of vaccination. And there's lots of concern from people wanting to make sure they've got that evidence of vaccination ready to go for when they need it. So getting those records on air is very important. And they're recorded by your practice software, or you can do them directly via the AIR site. And while we're on the topic of AIR, did you know that the authentication file access is being closed on the 30th of September? So that is not very long away. So that if you're still using your authentication files and you don't have a Proda login, you need to get on it before then, otherwise you won't be able to get into AIR, and you won't be able to upload your records to AIR. So that's the transition to the Proda. That's the provider digital access site for AIR. If you don't have it, then the Primary Health Network will be more than happy to help you get set up. All right, so moving on to adverse events following immunisation.
Would you like the COVID questions, Sally?
Oh, yeah, that'd be good, thanks.
Okay, there's quite a few, needless to say. One was about, is it fair to assume if schools were open, school age transmission would be higher?
I couldn't say that definitively. The previous thinking on it was that they were a low risk setting for transmission, but all bets are off for the Delta strain. So I couldn't say, if you're asking my personal opinion, I would think so, yes. No different to the rest of the community when we open that up. But I don't know what the thought on it is. But yeah, as I said, it used to be with the other strains, they were seen as low risk settings for transmission.
Do we know what the rate of long COVID syndrome is amongst the various age groups in Australia?
I don't know about in Australia. I'm not a infectious diseases person, so I don't know the ins and outs of the disease itself and the epidemiology and what's going on with it. And it's an evolving thing. So I haven't seen or heard mention of the long COVID rates in Australia, and I'm not even sure how prevalent it is worldwide. But yeah, that would be something interesting to see and keep an eye out for.
Okay, and there was a question on storage temperatures, but you've answered that. Can EENs give COVID vaccines or only ANIs?
It depends. So authorised nurse immunisers can give the vaccines. So the authority allows them to give vaccines without prescription, without medical supervision. Endorsed enrolled nurses can give vaccines like any other intramuscular injection that they give, but it has to be under prescription. So you would be, if you're working in that capacity, you would need to be in a GP practice supervised by a GP. If you're at a hub, I don't know how it would work at a hub, to be honest, because so the authority only covers registered nurses and midwives. There's no mention of endorsed enrolled nurses, while some of the immunisation courses, I know there's ACN, the Australian College of Nursing, enrolled nurses can do that course. However, you aren't able to operate as an authorised nurse immuniser. But you can provide vaccines like you do at the practice anyway, but it has to be under script from the doctor. So the doctor has seen the patient, assessed them, prescribed it, and then sent them into you to give the vaccine.
Do we know if and when there's likely to be a booster for COVID?
A booster for COVID?
Yes, sorry, the questions all just jumped and I lost it. Is it known when a booster, they're coming in thick and fast, so you call a halt when you want to move on to something else?
Sure. No, there's no word of that at this stage. We're getting the, I think it's 25 million odd doses of Moderna as part of the delivery for with the intention to booster. I understand some other countries are starting to look at boostering, but in Australia, we're still trying to get our first and second doses in. So there's no talk, and not on my level anyway, of what the plan is for boostering.
If an infant has been diagnosed with COVID, how soon after can you give them their childhood immunisation?
I would think as long as they're well and they've had, at least a couple of weeks post illness to recover, then that would be all right. I'd say our usual rule of thumb is 2 weeks. So the childhood immunisation, yeah. So if you're talking about somebody else who's had COVID, there was the 6-month wait, but for their childhood immunisation, so you're not giving a COVID vaccine, 2 weeks after their acute illness.
There's been a couple of questions on, people are eligible, but their availability is a different question. And I'm not sure if you have an answer to that one.
Availability of the vaccine. Oh, yes, yeah, absolutely. The eligibility versus availability, it has always been an issue since the day dot with these vaccines. Unfortunately, we just haven't had enough supplies. Hopefully, towards the end of next month, we will have more than enough to be able to roll out the program to everyone who these vaccines are registered for. And
so do breastfeeding women qualify as a priority group if women decide to delay vaccination to postnatal period or can't get an appointment till after the baby is due?
No, so it's only pregnant women who are a priority group.
Why are COVID vaccine batch numbers not being recorded on air?
They are recorded on air, but when you print off your immunisation history statements, they don't provide the batch number. I don't know why. That's the Commonwealth's responsibility. It's just always been that way, that when you print off an immunisation history statement, it tells you the vaccine you've had and the date you had it, and that's it. But if you look on their records, when you log in to AIR, you'll see that there are batch numbers there.
And if a patient has already had COVID, is there a preference for the vaccine that they should receive, or just either?
Yeah, no preference. They should get the one that's age appropriate for them. All right, I might just move on to adverse events. with the COVID vaccines. I just want to go over the surveillance systems that we have, just so you guys know what goes on in the background with these vaccines, that we don't just throw a new vaccine out there and then let it do its thing. There's lots of things that happen behind the scenes. So the surveillance systems that we have in place previously, up until recently, they were mostly passive surveillance systems, and those passive surveillance systems are basically, we give you a vaccine and then we wait for you to come and tell us you had a problem from it. We don't go looking. So that passive surveillance system has been included in the New South Wales Public Health Act, where it is a requirement to report an adverse event following immunisation to the Public Health Unit. So we rely on you guys as immunisation providers and treating physicians and clinicians to feed that information back to us and report it to us. And that isn't the most ideal way of managing adverse events. So while we still require that, we have implemented some active surveillance systems, and AusVac Safety is the one that we use in Australia. And that is a combination of a few interfaces that provide data. So that's VaxTracker and SmartVax. And they provide data to AusVac Safety, which analyse the data and provide that information on some websites, which I'll show you in a minute. And that is in the form of an SMS that is sent to everyone that receives, everyone who's registered with VaxTracker or SmartVax, and they'll receive an SMS that 3 days after vaccination, I think it's 7 days after, and we'll ask them, did you have an adverse event following your immunisation? And when they indicate yes, it'll then take them to a survey that asks them what went on, what happened, and gets down to the nitty-gritty. If it's something that is concerning and severe, up until recently was being followed up. Now it's being used as just a sentinel, a monitoring and reporting mechanism. That's the AusVac Safety. We have the Public Health Rapid Emergency Disease and Syndromic Surveillance System, and that's the FREDS. And that we've been doing that for years, which is all emergency departments, public emergency departments are linked into this system, that if there is a key word relating to immunisation, and they have hundreds, so it might be vaccine, immunisation, COVID, measles, all of these words that may indicate that somebody's come to emergency because they've had a problem with their vaccine, it triggers an event with the Ministry of Health, and then they'll analyse that and then direct any cases for review to us at the public health units. And then they've also established a baseline rate of adverse events of special interest. So those are adverse events that we're particularly interested in relating to the vaccine or vaccines in general. So, you know, TTS, pericarditis and myocarditis, those are all of special interest to us. Also Guillain-Barré, Bell's palsy, those kinds of events following immunisation. So yeah, we've got a good guideline and baseline rate that we monitor. So this is the SmartVax for GP practices. So SmartVax is the interface that GPs can use, and that if you go to that website, the SmartVax website, you can register there, but I understand there are limited spaces for funded spots. I think they are thinking of developing a model for user pays, but if it's something you are interested in, you can go there and have a look at what it is that they do. But that's the GP interface, and then the New South Wales Health sites use the VaxTracker, which is the interface which was initially developed through Hunter New England Local Health District. And so all of the hubs use that, and yeah, all of the hubs in any New South Wales Health sites. And this is what, so those two interfaces then bring the data to OSFAC Safety, and this is the information that is available from those SMSs that have been sent out. So as of the 16th of August, they've sent almost 4 million surveys out, and they've had 2.4 million people who've responded, which is close to 62%, which is a pretty good response rate for a survey. And then you can see that 54.3% of participants have reported no adverse event, and 45.7% have had a adverse event, and 0.9% of those were significant enough that they needed to seek medical treatment for it. So 0.9% doesn't sound like much, but when you're dealing on the population levels and the numbers that we're dealing with, it's a lot of people that are notifying of adverse events that are serious enough or thought to be serious enough that they need to seek medical attention for. And the other information that they include is each of the states, so you can see what response rate to those surveys that they've had. And then they also break it down, which I'll go into in a sec, for each of the vaccines, but we'll go into that in a sec. So reporting. Report to us any uncommon, serious or unexpected adverse events. We don't need to know about the fevers and the aches and pains and feeling yucky. Those are common expected reactions. We want to know the uncommon, the serious, the unexpected. It's considered serious if it resulted in death, if it was life-threatening, required hospitalisation. So that's admission to hospital, not presentation to emergency. If there's a significant disability or incapacity related to it, if there was a congenital anomaly or a birth defect, or if it doesn't fit into the common reactions for that vaccine that are outlined in the product information. So those need to be reported to us. In New South Wales, we report through the public health units, through us at the public health units. We report to the TGA, but we like it to come through to us first so that we can investigate, we can gather the information that we need on each case, and then that information is relayed by the Ministry of Health to the TGA. So if you, there are TGA reporting forms online. We would prefer that you send them to us if they're serious or uncommon. You can report the less serious ones directly to the TGA, but if there's anything you've got that's serious, please send it to us. The adverse reactions with the Pfizer vaccine, we're seeing that they're usually mild and resolve within a few days. The biggest complaint is injection site pain, lots of fatigue and headaches, and the usual myalgias, chills and arthralgias, and fevers and injection site swelling at 10%. With Pfizer, there's a higher frequency of fevers after the second dose. This is the OSFAC safety data for the Pfizer vaccine, the first dose of the Pfizer vaccine. You can see that 62.8% of people reported no adverse event, which is not bad for a vaccine. And then the more common ones, you can see the percentage rate. The injection site pain is by far the most common reported reaction, and only 0.5% of people needed to see a doctor after that first dose. After their second dose, you see what I was saying before, that people are reporting more adverse events after dose 2. So after the second dose, that changes, and it's only 43.6% who have had no adverse event. The biggest complaint is fatigue and injection site pain, and 1.3% of people have gone to a doctor compared to the 0.5 after dose 1. So you would expect there to be more pronounced illness and complaint after dose 2. So good to counsel your patients of that, let them know what they're to expect. I find if people are prepared and know what's happening and what's going to happen, then they're less likely to be taken by surprise. With the AstraZeneca vaccine, again, usually mild to moderate type symptoms, which resolve within a few days. Sore arm is the biggest complaint, but also headache and fatigue, and very similar myalgias, malaises, a bit of a fever, and in 30%, and a small amount have nausea and arthralgia. And they have the opposite in that the second dose, the reports of adverse events are milder and less frequent. So we saw a lot of people, especially with AstraZeneca, before it was, we realised that there was an association with the TTS, so all ages were getting it. A lot of complaints after dose 1 with the AstraZeneca vaccine about feeling like they were hit by a truck, and really the younger they were, the worse off they felt following the vaccine, and that was very reflective of the research that had been done. So you can see it's different with AstraZeneca. It's a reverse with the to the Pfizer. Only 44.4% reported no adverse event. So the majority of people had reported an adverse event after dose 1, and 1% of those people sought medical treatment. Then after dose 2, 73.6% reported no adverse event at all. So that's quite a significant amount, and only 0.5% sought any kind of medical treatment. So it's interesting to see this data. It's, you know, it reflects the, you know, the work that you guys are doing out there, and what you'd be seeing when people come back for dose 2, and if it's the Pfizer, saying it wasn't that big a deal, but then after dose 2, it felt like they were hit by a truck. It's interesting to see that is exactly what's happening with this data. So with Moderna, this is from the product information. So we obviously aren't using that yet, but that has similar reactions to the Pfizer vaccine. So by far and above, the injection site pain is the biggest complaint. Almost 100% of people are complaining of injection site pain. And then the other common type reactions, the fatigues, headaches, myalgias. Systemic reactions were more common after the second dose compared to the first dose. So those fevers, chills, those were worse after dose 2, similar to Pfizer, and more common in the younger age groups, which we've been seeing with the Pfizer as well. So when these adverse events are reported to us, they're investigated quite thoroughly. So there has been a public health inquiry established under the Public Health Act, and they are looking at and monitoring and investigating the effectiveness of the program. Us at the Public Health Unit and the New South Wales Immunisation Specialist Service investigate all serious and unexpected APHEs and ACEs. So we, as I said, we get those threads. That has been quite a increase in traffic for us at the Public Health Unit. So we've had to expand our team. I think we've doubled in size now to manage all the adverse events. So we get those threads daily, but we also get direct notifications. We get notifications from the TGA, notifications from the Ministry of Health, and then there's the phone calls and the faxes and the emails with APHEs as well. So we've put those on into our notifiable database, and we gather their medical records. We will consult with their treating physicians, and then we consult with the New South Wales Immunisation Specialist Service, and they provide us with advice for future vaccination as well. There's a safety expert panel with New South Wales Health, and they have adult and paediatric specialists that review serious adverse events. So that panel meets several times a week, and the co-chair will decide which cases need to be discussed, and they will make recommendations to the TGA based on those discussions. If there are any unexpected deaths after the vaccines, the coroner will get involved to determine whether there's a temporal association with the death and the vaccine. And there's also the forensic pathologist who will conduct relevant investigations. So it's a very closely monitored program. We're very keen to ensure that there's lots of transparency. So that's why it's great that that data is out there for anyone to see at AusVac Safety. And then the TGA also will do regular reports of adverse events after the vaccines. So yeah, you can assure your patients that we do follow these up and we take it very seriously.
A couple of questions in that, yep. Sally. One, I've come across a case of clot developed after the first AstraZeneca. Person was treated at hospital. Do I still need to report the adverse event, or is it assumed the incident has been recorded at hospital?
I wouldn't assume it. There's no harm in reporting it. You can ring us up and ask, and we can look and see if we know about it. Quite often we get double up, so we'll get three different sources reporting an adverse event. We'd rather have too many than not have it reported at all. So feel free to give us a ring and ask. We're more than happy to discuss.
And I think that probably answers this question then. If a patient replies to the AusVac SmartVax SMS as having seen medical advice following vaccine adverse event, do we need to be following these up and completing AFI report? Sometimes patients see other medical practitioners with issues following vaccine, and one would assume the other GP has reported it.
If you're getting reports of people coming to your practice after with an adverse event, you should be reporting them. I'm not quite sure what happens with SmartVax if you guys get told of the adverse event, or if the data just goes straight to AusVac Safety. But if you're getting told, or a patient's telling you that they've had an adverse event, then you should be reporting it.
Okay, I think that's the only couple on AFIs for the moment. Yep.
So if you need clinical advice, you can give us a call at the Public Health Unit. We're here in business hours. We can give you advice on whether it's a notifiable issue. We also, as you know, give general immunisation advice. The New South Wales Immunisation Specialist Advice Line, they're open during business hours on their 1800 number. They were had gone to email, but I did notice today that they're back taking messages on their phones. So call that number and leave a message. They're very good at getting back to you. And then they also offer an after-hours service for any serious AFIs that need investigation or management, and they're contactable through the switchboard at Children's Hospital. You can refer your patients to InSwiss. InSwiss will see children, basically. They don't have an adult service, unfortunately, but they're more than happy to provide verbal advice over the phone. So feel free to give them a ring. But if you do have a young person, somebody under the age of 16 that has had an adverse event, then you can refer them to their, not so much applicable at the moment with COVID, but with their childhood immunisations, you can always refer them there. All right, so just a quick skim through calculating catch-ups, because we're going to run out of time. Oh God, we've run out of time. Is it 9 o'clock already? We've run out of time. So just I'm going to whiz through the rest of these slides. The catch-up principles, we'll send you out a copy of these, but basically you should catch everybody up for everything they're overdue on that visit. Please don't split vaccines. It's not recommended. If they're due 4 vaccines, they should get all 4 vaccines at that visit. And I know parents can be reluctant to do it, but we'd really like you to try to encourage them to ensure, provide assurance that we're just trying to get them caught up and covered for as much as possible. And when you split vaccines, it makes their schedules quite complicated, and that's when errors happen. So product information is great, but always remember the ATAGI advice is the best practice advice, and that overrides anything in the product information. These are the minimum dose intervals for catch-up. I've been through them with you before if you've been to my presentation, so I won't go in detail, but they'll be there for you to refer to. But that's just when you're doing catch-up, you need to make sure there are minimum intervals between certain vaccines. That's the hepatitis B, which is the trickiest one. Then there are also acceptable variations to the hepatitis B schedules. So you can give, you can't give it in Australia, but you can accept from overseas a birth dose plus dose 1 at 1 to 2 months and dose 2 at 6 to 18 months of age. And then there's the adolescent hepatitis B. If you've got an adolescent being caught up at 11 to 15 years of age, 2 adult formulations of the monovalent hepatitis B 4 months apart, and that's all they need. And then there's age limits when you're catching kids up, just being mindful that each vaccine is only suitable for certain ages. There are tools available to you at Northern Sydney. We have the under 10-year-old catch-up table that you can refer to, and you can calculate it yourself if you're so inclined. However, the online handbook now has a catch-up calculator for anyone under 10 years of age. And that's a really handy tool. It just basically, you input their dates of birth and previous vaccination history, and then this is the schedule that it churns out for you. So it tells you give now, next appointment, future appointments at these dates, assuming they come on the dates they're supposed to come. So that is, if you go to the immunisation the handbook online, you'll find the calculator there. For people over 10 years of age, they're working on it for the immunisation calculator, but unfortunately there's nothing available yet. But at Northern Sydney, we have a table that helps you with the doses, how many doses they should have and how far apart they should be. And you can get them at that link. The adolescent program, you'd all be familiar with, that has been paused, as you know, until at least term 4. We don't know what's happening there, and we don't know what's happening for the COVID program. There's no mention yet of us having a COVID vaccination program for high schools, but we're very keenly waiting to hear what's going on in that sphere. With HPV, the recommendations you'd be aware of for the adolescents, 2 doses 6 months apart if they're aged 11 to 14. But if they're 15 and over, or if they're immunocompromised, it's a 3-dose schedule, and that's given at 0, 2 and 6 months. Just having a look at the incidence of cervical cancer in Australia, you can see that's when cervical screening came in, and then that's when the HPV vaccination program came in. And it's not, you wouldn't expect to see much. Cervical cancer is kind of a long-range thing to see a benefit. But if you have a look at the incidence of genital warts, which many of the strains in their vaccines cover, that you see a more immediate response to the vaccination program. So this was when the program started in 2007, and in women was when we first started vaccinating, and you can see that there was a pretty much immediate drop in the under 21s is the blue, and then the 21 to 30s. The over 30s, not so much of a drop, but you wouldn't expect to see that in that age group. And then in 2013, we added boys into the schedule, and you can see there's a little bit more of a drop there as well. In men, in 2007, they had the benefit of heterosexual men of the rates of genital warts in those population dropping with the girls being vaccinated. And then with the addition of them to the 2013 schedule, you can see drops in those groups as well. So it is anticipated that in the years to come, when these age groups get to those ages where they're more likely to develop cervical cancers, we're not going to see the rates that we used to see. And it's been a very successful program. For high school records, we're putting them all on the Australian Immunisation Register now, so check there. Vaccinating adults, it's just the usual principle, you know, looking at where they live, what they do for a living, where they're travelling, those are how you work out risks and what you need to be vaccinating them for. There are tools available through the National Centre for Immunisation Research and Surveillance that provide you with a list of recommended vaccines for these groups of people. And for non-Indigenous and Indigenous people. Vaccinating pregnant women, you'd be very aware that it is recommended for 20 to 32 weeks gestation. You ideally do it in that period, but you would do it right up until they give birth. If they haven't come to you by 32 weeks, you would still give it. It's still good to give right up until they're in the labour ward. We do it because it provides that passive protection for the newborn, and it has been shown to significantly reduce the morbidity in infants, particularly those aged under 3 months. And so it's been the most effective program that we have in preventing those infections. It doesn't prevent mild illness, so it still circulates, and babies are still contracting pertussis that have been vaccinated in utero, or their mums were vaccinated and they received that passive protection in utero. But the illness is much milder, so less hospitalisations and less deaths. Influenza, same thing. It's very important to ensure that women are vaccinated during pregnancy, at any stage of pregnancy. We don't wait for any particular trimester. If they're pregnant and coming to you and there's an influenza vaccine available, please make sure you're vaccinating them. They're far more likely to develop complications if they're pregnant and they contract influenza. And again, it provides that passive protection for babies, especially those under 6 months of age, because they're too young to be vaccinated. And it's shown to prove to decrease that risk of hospitalisation in that age group, and by about 50%. As I said, any time during pregnancy. Sorry, I'm having to rush through this, so I've seriously mistimed the length of time this was going to take. I think maybe I got thrown off by the questions. So this is nothing new. The Occupational Health Assessment, Screening and Vaccination against Specified Infectious Diseases policy directive that I referred to before, New South Wales Health, and how we vaccinate our workers. And those were the changes in 2018 and 2020. I went over those last year in my update, so there's nothing new there. There haven't been any changes since. And those are just appendices from the documents that list what people need to be vaccinated for, and the proof of immunity from the hepatitis B with the measles, mumps and rubella. If they've had 2 vaccines, please don't check their immunity. If they've had 2 vaccines, that is sufficient evidence. There's no need to check their immunity. As I said, we often get false negatives. The only reason you would check their immunity is if you didn't have a record of vaccination and they were born after, they were born before 1960s. No. Yeah, you'd only check their immunity if there was no record of vaccination and you weren't sure whether they were immune. If they were born before 1966, immunity is assumed, so you don't need to check it. And if they're born after 1966, you can check immunity, but you may find you still need to do the 2 vaccinations anyway, so you can give them the option. And they're the other vaccines, the varicella, the tuberculosis screening that they need to have. All right, I'm getting there. I'm at the end. So what else is new? Just a quick whiz. Handbook. It's in an app now. Highly recommend it. You can use it offline. It's much more user-friendly than the online version. Very similar format, but the online version, you can't use it if you don't have a web connection. This you can use as with any app, and it updates frequently. The sharing knowledge about immunisation, that's been around for a while now. I mentioned that last year. Important to note that there are new HESA approved courses. So previously, the only course that allowed people to work as authorised nurse immunisers in New South Wales was the ACN Immunisation for Health Practitioners course, which is expensive and takes a bit of time. It's all done distance. Great course, but a little bit restrictive for some people because it's not the most affordable in the world. So fortunately now we have some more courses available, and all of these courses allow you to work as an authorised nurse immuniser. So the one from South Australia is 70 hours online and it's only $225. So check them out. Those are the names of the courses. You'll find them freely online, and all of those being HESA approved, you can work as an authorised nurse immuniser. And just to mention that the vaccination standards have changed for the pharmacists, so that now they can vaccinate for COVID vaccine, but only AstraZeneca. Pharmacists can only do AstraZeneca 18 years and older. And that's the bulk of it. There's links and resources at the end of the presentation, which you guys can access when I'll send this to the PHN and they can circulate that for you. Handbook, online handbook, questions about vaccination. You'd know all of these. These have all been around for ages. Yep, that's it. Sorry, I'm so sorry I went over time. Thank you everyone for your patience. And I'm happy to stay back and answer any questions if anyone has any they want to ask.
Thank you, Sally. There are a few unanswered questions on there. We can see if people leave or not. If you have to go, fully understand. Either answer the evaluation when it comes as you sign out, or please, if not, when you get the email tomorrow. Thank you very much, Sally. That was absolutely fantastic. So much information. Keep everybody thinking for a while. And could I just say, if you're having trouble with PRODA and accessing the air, do contact the Primary Health Network. We can help you sort that out. Authorised nurse immunisers can't get direct access to air, they need a delegation, but just contact your Primary Health Network and we'll help you. So thank you everybody that's leaving. Sally, if you want to stay online, we'll see who goes. If you're, we'll just answer the questions. There's a few dropping off, but a few are staying. So let me see, I'll go right up to the beginning. There were a few odd ones. There was a question about the third dose of Gardasil not being funded. That's still the case?
That's still the case. There's only two doses funded.
Right. And the same
up to the 20th birthday.
Up to the 20th birthday. And the 10 to 19 years catch up, why are they not funded?
The 10 to 19 years catch up, why they're not funded? They are funded.
Okay.
That might mean maybe that was in reference to who's entitled to funded vaccines, and that was around the Medicare, if they've got Medicare cards, if they've got Medicare, access to Medicare, then they're entitled to funded vaccines, basically.
And the recording of the Hep B given at birth. Now, I know currently general practice can go in and enter that manually. Vaccines given at the hospital are not generally entered into the air. Will they be doing that from here on in? Yes.
So all of the hospital sites have now set up in PRODA, and I'm not sure how they're doing it, but I understand there's a project where EMR, which is electronic medical records, will interface with AIR, and those records will be uploaded to AIR.
Fantastic. Apart from liver disease, what are the other complications as an adult who has had Hep B?
Well, I mean, it's the liver. It's a viral illness that attacks the liver. So, I mean, I'm just trying to think. Apart from complications of the liver, I mean, yeah, I can't answer that. Again, I'm not an infectious diseases person, but that's probably one to ask someone that knows more about these diseases than me. But I can't think of anything else other than liver problems.
And the second varicella dose/booster recommended in the handbook, is it necessary?
Yeah, it you know, depends on your definition of necessary. It's yes, it's highly recommended. We see a lot of breakthrough illness with chickenpox. So even in vaccinated kids, if they've only had one vaccine, two reduces that risk of breakthrough illness. So it's something that you should be discussing with every parent and offering. Unfortunately, we don't have 2 funded doses, but funding doesn't necessarily indicate importance. So just because it's not funded doesn't mean it's not important. So I always recommend that second dose because it is not only likely to reduce the risk of breakthrough illness, but it will also reduce that likelihood of you going on to have shingles and zoster type episodes.
And does the chickenpox vaccination give you the risk of having shingles?
Not that I'm aware of. I haven't heard any, and if it did, I wouldn't have thought it was something that introduced to the into the program, because then it would defeat the purpose of having the vaccine. I would have thought, yes, it's a live vaccine, but because it's an inactivated vaccine, then there's no evidence currently that it reduces the incidence of shingles. That it causes an increased incidence of shingles.
And Zostavax versus Shingrix, assuming you're not immunocompromised, is one better than the other?
Well, I don't know much about Shingrix, but if you look at that product information, the statistics that I looked at, the Shingrix appears to be more effective than the Zostavax at reducing the likelihood of having zoster and having post-hepatic neuralgias. So on paper, the Shingrix looks more effective than the Zostavax.
And a COVID question, if people are immunocompromised, would a third dose be recommended?
Not at this stage. That's something, you know, it's a very new, these are very new vaccines, so they continue to do their post-marketing surveillance of things. So they'll still be following up cohorts to see how their how their immunity is further down the track. So it's quite possible that they may need boostering, but currently there's no advice for that.
There's a comment here about one of the hubs scheduling 8 weeks between vaccinations for the Pfizer. Is this too late?
It's never too late. I wasn't aware of that being a routine thing. It was my understanding that it was that we were recommending that you could expand it out to 6 weeks, but I'm not sure about the 8. But it's never too late. You build your immunity on previous doses, so you would still go ahead and get that second dose.
How can COVID vaccination that was done overseas be entered into air? And my answer to that would be manually.
Yes, manually. They are entered into air, but there's a problem with air at the moment where it doesn't recognise any vaccines given before March 2021, sorry, because our program in Australia didn't start till March, and for whatever reason, air has decided nobody else in the world got a vaccine before then. So it's a problem that we have raised with the Commonwealth for fixing in air, but until that gets fixed, unfortunately, those overseas records can't go on air. However, please discourage anyone who's seeking additional vaccination so that it can go on air. It will get fixed. They don't need any more vaccines just to get a record on air.
Is there a specific time frame for the development of myocarditis and pericarditis post-Pfizer? You might have mentioned that.
Yeah, I did.
Okay.
I think it was 1 to 5 days from memory. I'd have to go back and look though.
All right. And if a person's recovered from COVID, but in the light of what's happening and wants a vaccination earlier than 6 months, is it a case-by-case basis?
Yeah, I mean, the immunity, they've shown that immunity from infection is good for at least 6 months. So yes, it's just something you can discuss in consultation with your doctor. There's no harm in it. There's no concern that there'll be any damage from it. But yeah, you've got to kind of weigh up your risk versus benefit. So if you're at risk and you're concerned about it, there's no harm in doing it sooner, but discuss it with your doctor.
And if you don't have a reaction to AstraZeneca, does it mean you may not have as good an immune response?
No. So everybody's different and everyone's immune system's different. While having a reaction is an indication that, yes, you're mounting a good immune response, it doesn't mean that you not having a reaction doesn't mean that you haven't. They've done studies with people who have had pronounced side effects after the vaccine and compared it to people who didn't, and they had equal levels of antibodies. There was no difference between them.
If anybody comes in for school vaccination to their general practitioner, can we offer it now, considering the current situation?
Yeah, I would say so. I mean, we do, like I said, we do like to keep people in the school program if we can, but we also want to make sure that these people are covered and protected for these vaccine preventable diseases. So if they're there and they're wanting to be vaccinated, go for it.
Have there been any adverse events for pregnant women and their unborn baby?
Not that I'm aware of. It's been shown to be very safe. I mean, when I say no, not that I'm aware of, but that doesn't mean that it hasn't happened. I mean, being pregnant doesn't mean that you're not there's not a chance that you could develop myocarditis or pericarditis. But I haven't heard of it. And as I said, it's very mild, the incidences, most of them, and resolve quite quickly. So it's quite possible that pregnant women have had some adverse events, but no severe adverse events that I'm aware of.
And how long does immunity last after vaccination, 2 doses?
We don't know. It's so new that we'll continue to study it. And it depends too. The Delta variant changes the landscape too. So at this stage, we're not planning boostering, but well, when I say we're not planning boostering, we've purchased doses to booster next year on the assumption that we'll need to booster. Given how these strains have mutated and things change, it's quite probable that we'll need to booster. But at this stage, I haven't heard anything about how long. I just don't think we've been doing the vaccination programs long enough to get any good data on how long the immunity is lasting from vaccination.
Is vasovagal considered an adverse event?
No. Well, yes. Yes, it is considered an adverse event because you're having an adverse event after immunisation. It's not considered a reportable or a notifiable adverse event. It's common, it's expected, it's self-limiting, it's not life-threatening. So while we know it happens, you don't need to report it.
Question here about some hubs are using vaccination workers like nursing students. Are GPs able to do that soon?
I don't know. It would depend on how the Commonwealth has set the program up. You certainly wouldn't be able to use them in the capacity as like an authorised nurse immuniser. You know, they couldn't operate independently. They would need to be supervised and have, you know, all the medical assessment and everything would need to be done properly. So I don't know is the answer to that. Possibly they'll expand it. This landscape is forever changing.
It's my understanding currently that the people putting the vaccines in the arms have to be authorised to do that in the sense of through their training, so general practitioner, registered nurse, a pharmacist, etc. The student, yeah. Would she be a vaccinator, an immuniser? Can they do immunisations?
Students? Yeah, they do them in hospitals. So, but then that's under direct supervision of a registered nurse, and you know, there's medical. It's on script. So, yeah, it would depend on how the Commonwealth sets the program up, and I'm not aware of that being a plan at this stage.
And the question about batch numbers earlier, it was actually in the context, they just repeated it because they've been told this was a requirement for travel overseas, having the batch number recorded on the air immunisation history.
What was that? The batch number being recorded?
There was a question earlier about the batch numbers not being recorded, and you were saying they don't show on the history.
No.
The question is that because they don't show on the history, she believed it was a requirement for travel overseas.
Yeah, it's possible, and that's something that has also been raised with the Commonwealth. So it may be something that will change going forward, but currently the batch numbers don't show on the history statement, and I'm not sure why. It's just never has.
And then the change of name for the AZ vaccine, is that being changed to make it recognised worldwide?
I think it has. It hasn't been widely published though, but yes, I did see it mentioned recently in one of the documents I was reading, but I forget what it was.
Yes, we sent the information out to general practices yesterday, I think. Do you know if there are any plans for clinical trials for COVID vaccination in children under 12 in Australia?
Not in Australia that I'm aware of. There's certainly plans for clinical trials worldwide, but I'm not aware of anything in Australia. That doesn't mean it's not planned. I'm just not aware of it.
And the last one, I think I might have asked you this, goodness, I'm losing my marbles. If they introduce COVID vaccination in general, would that be through the schools program? Would it be added to the schools program, I think is the question.
Oh, okay. I don't know. I mean, who knows how it's going to occur. I would think yes, but you know, that's a huge change to the program. You know, we're currently vaccinating about roughly 20,000 kids a year, and then we'd be having to throw in another 30,000 on top of that. So so it's a possibility, but yeah, I haven't heard anything on what the plan is.
And then one final question, if they have a mixed schedule, it's not showing as fully vaccinated on the air, but my understanding is they can use the vaccination history, which will show both doses, and that statement at the top that says they don't meet the requirement has been removed.
Oh, okay.
So if they have a mixed schedule, they weren't getting the green tick to say you're fully vaccinated.
Oh, yeah.
If they use their history statement, it will show both vaccinations, and that would suffice.
Oh, okay. All right. Well, I wasn't aware of that. I knew that there was a problem with mixed vaccination schedules, and it was being addressed.
Yes.
So hopefully that's fixed that.
Yes, well, I think it will show them as fully vaccinated, but currently the vaccination history will show both vaccines. So they just won't have the box tick that says they're fully vaccinated, but it's being sorted. And any issues noted with fertility?
No, there none at all. It's been studied, and there's a bit of misconception and misinformation circulating about that, but no, it doesn't have any effect on fertility at all.
All right. Well, the rest of the things that we haven't answered, say thank you, Sally. Thank you, Sally. Thank you, Sally. Thank you, Sally. Wonderful. Thank you.
Thank you
very much from all of us.